A very good day to everyone. I am Dr. Rajeentheran Suntheralingam, urologist with special interest in urodynamics. My presentation today is on overview of urodynamics, a very broad overview, general idea of what urodynamics is all about. The best way to know about urodynamics is to attend the urodynamic workshop. Now basically, what's urodynamics? Urodynamics is a group of diagnostic procedures performed to evaluate voiding disorders, including lower and upper urinary tracts. Normally, it implies lower urinary tract, but there are some urodynamic procedures which you use for upper urinary tract itself. Basically, what we do is we do a diagnostic procedure by placing catheters into the urethra and the rectum to determine the bladder voiding disorders. That means the bladder passing urine, any problems or anything like that. The parameters measured during the urodynamic is pressures, flow, EMG, and video imaging. Now, what's the basic aim of doing a urodynamic? Actually, there are two basic aims. Now, when a patient comes with urinary problems which cannot be solved, first and foremost, we need to do a urodynamic to find out exactly what's happening. Now, urodynamic is not like an ECG. It's not only about tracing. We have to ensure that we manage to reproduce the patient's same symptomatic complaints. In other words, the patient has got a problem. During the urodynamic, the same symptoms has to be reproduced. And then based on the tracings that are due to symptoms that are reproduced, then only we have to interpret exactly what the problem is. And the second basic aim is to provide pathophysiological explanation of patient's problems. That means exactly what's the patient problem and then make a diagnosis, exactly what you think actual diagnosis. Now, what are the indications of doing a urodynamic? We do a urodynamic for neuropathic cases, that means neurological cases where there's voiding dysfunction. In other words, the bladder is not functioning well. In many urge syndromes in women which failed conservative management, in males with outflow obstruction, that means urinary problem, outflow obstruction, less than 50 years of age, or those more than 80 years of age. Post-prostatectomy syndromes, that means after once a person removes the prostate, they have a lot of problems, urinary problems, passing urine problems, difficulty in voiding, then we do a urodynamic. Incontinence, not all incontinence. If it's a simple stress incontinence, maybe you don't need any urodynamic. But any incontinence which is leaking of the urine involving more complicated cases, then we proceed urodynamics. Children with complex voiding and incontinence problem, yes, that's an indication. Women in stress incontinence, especially after failed surgery, or some people advocate for before all surgeries. Women with recalcitrant UTI or urinary tract infection in equivocal flow rates, and young men with persistent prostatitis. Now, what's the indications of ambulatory studies? We very rarely do ambulatory studies. But ambulatory studies are basically putting in a catheter and asking the patient to walk around for a few hours or the rest of the day, and where measurements are done. Now, the measurements can be, we can always have false measurements, so one has to be able to properly read the tracings properly. Now, what are the indications of ambulatory studies? Patient whom conventional urodynamic studies demonstrate no abnormalities at all in the presence of significant symptoms, especially in women with persistent urge syndromes unexplained in conventional urodynamics, youngsters with persistent nocturnal and diurnal aneurysms to exactly find out what's happening, and where conventional urodynamics fail to provide an explanation of the urinary problems. Now, in urodynamics, we need to know certain nomenclatures used in urodynamics, the various types of pressures, which is intra-abdominal, vesical, detusa, urethral pressure, and urethral closure pressures. We need to know what is Q-ura and Q-max, which is maximum urinary flow. We need to know what's EMG, and we need to understand the fact that detusa pressures is a subtraction of intra-abdominal pressures from that of intravesical pressures, and closure pressures of the urethra is a subtraction of the urethral pressures to that of the intravesical pressures. Now, to understand urodynamics, you need to know a lot of basic understanding of the background of the disease, as well as the phases of micturition. Basically, the three phases of micturition. The first is when the bladder is filling, where the bladder neck is closed, external sphincter is closed, and the bladder is relaxed. The second is during voiding or passing urine, when the bladder neck is open, external sphincter is open, and the bladder contracts. And the third phase is when the external sphincter is contracted and the bladder is relaxed. And one need to know all the different phases with all the different pressures that can occur, and the external sphincter EMG activity. Now, for urodynamic, we need to know, actually do a basic assessment before any urodynamic. We just cannot place the patient under urodynamic and do the EMG tracings and the Euroflow and urodynamic systometric tracings. and then make a diagnosis. No, we need to do a proper assessment, because why? We need to reproduce the same symptoms the patient has to make a proper conclusion exactly of the urodynamic diagnosis. So history, we need to know exactly the history, what are the symptoms, how much of, if there's any leaking of the urine, how much amount leaks, when does it leak, patient performs when patient performing starts leaking, and whether she's got a neurological injury before. Examination need to focus towards the abdomen, see if the bladder is full, do a vaginal examination, rectal examination, check the pelvic floor strength, and do a focal neurological examination. Urine analysis is very important. It gives us at least a clue exactly what's happening in the bladder. We need to do a microscopy and culture, because if there's an infection, we shouldn't proceed with the urodynamic at all. We need to do a post-void residual volume to see how much of urine has managed to be passed out and how much is left back. Personally, I do both before and after, pre and post void residual volume. And we also need to do a voiding chart before any urodynamic, because we need to give the patient a chart, and where they'll chart how much they drink every day and how much of urine is passed out at different times of the day. Why? Because sometimes instead of just urinary frequency in the night, for example, nocturia, it may actually be nocturnal. It's not due to frequency alone, but it's due to excessive volume. So what is a uroflow? Uroflow is a basic simple investigation where you do before the proper conventional urodynamic is done. Basically, the patient passes urine into a toilet bowl, which is connected to a computerized toilet bowl, and the flow is measured by the computer itself. Now basically there are a few parameters where we need to look at during the uroflow itself. Is voided volume, maximum flow rate, average flow rate, time to the maximum flow, voiding time, and the flow time. Most important is actually the pattern. We need to know the pattern of the uroflow itself. Okay, these are parameters I've already mentioned. This is just a graphical representation. Okay, and this is how we usually write our results. We denote all the different parameters that we need to look. This is a bladder scan and bladder report. This is actually a post-void scan. I usually do pre and post-void. You can actually show by looking at the bladder scan, we can know what's the post-void residual and determine what's the bladder voiding efficiency itself. Now, uroflowmetry machines commercially are available in different varieties. The two main types are the weight transducers and rotating disc uroflowmeters. But there are others which are available, which are electromagnetic air displacement, hot wire, and drop spectrometer types of uroflow. But the most common is the weight transducer and rotating disc. Now this is a rotating disc where the patient passes the urine right into the bowl there. As soon as the urinary stream hits the rotating disc, it exerts a braking action, resistance, and this is converted into, by mathematical calculation, converted into the flow rate into the computer itself. And this is a gravitational transducer or weight transducer, where after the patient passes urine, is actually measured, the weight of the voided urine is measured, and it automatically calculates the rate of change of weight into the rate of the urine. This basically uroflow meter tracing. Look at that, the flow gets up and then suddenly gets down again very fast, like some sort of a hyperbolic curve or something like that. This is a normal flow. It should go up and come down again. Now this is abnormal flow. It's a poor flow. That means it's a plateauing. It doesn't go up. It cannot go up. It plateaus and it lengthens out for more than 20 to 30 seconds. And it comes up to even 50 seconds. So this is poor flow. When you see the uroflow, we can only say there is poor flow, but we cannot actually determine whether it's bladder outlet obstruction due to an obstruction or whether it's a weak bladder. Okay? To know that, we need to do a pressure flow study. Now this is an interrupter flow curve. You can see that it interrupts. Then the patient comes like a staccato widening. Comes and goes, and stops and goes. Some of these patients have another graphical representative of interrupter flow. You can see this in DSD or detrusor sphincter desynchronization. This is a super flow, very, very fast flow. All of a sudden, it even goes above the tracing itself. This is usually seen in patients who had got a bladder outlet obstruction, for example, a prostate enlargement or BPH, and somebody has done a TRP, resected it. The bladder is very thick, so the bladder really exerts a very high pressure, and the urine comes out very, very fast. Now, to understand uroflow and how to interpret the Euroflow readings, we need to also understand or troubleshoot these things. That means we need to know what are the artifacts that can occur itself. Okay, this is one of the artifacts you can see. We call it a spike artifact. So when you see the normal hyperbolic curve there, that's the maximum flow the patient has. But sometimes you suddenly see a spike because after passing urine, the patient suddenly accidentally kicks the Euroflow transducer, and suddenly you have a spike because they are very sensitive machines. So the reading will come out looking as a spike, a very fast flow. But one has to look at the pattern, look at the flow, and determine that this is an artifact. So in this diagram, it's not 15.1 ml per second, but in fact, it's only 9 ml per second. So reading just the report alone is not enough. One has to look at the Euroflow tracings and determine whether you are looking at an artifact. This is another artifact known as a WAG artifact, usually seen in males. Male passes urine and then they shake, they start moving here and there, and urine you can see it goes up and down like oscillating sort of thing. So that's a WAG artifact. So the spikes are actually wrong. We have to take the average. That means we have to make a proper curve and take the average maximum flow rate. This is a nervous artifact, quite commonly seen. The patient comes into the hall or the room to do a Euroflow, very, very nervous, can't pass urine very well, very poor flow. This is the same patient with the two Euroflow tracings. The first above is the nervous artifact, but when you repeat it, it's a normal flow. Now, what is the Qmax is the maximum flow. What is the so important maximum flow in BOO or bladder outlet obstruction? Now, especially in males, and this concerns males, especially in males between the age of 50 to 80 years of age. Now, when in between this age, when the Qmax is less than 10 ml per second, 90% of them most probably are obstructed. 10% may not be an obstruction which shows the poor flow, but it may be due to a weakness of the bladder. When the maximum flow or Qmax is 10 to 15, 65% of the cases may be obstructed and 35% may actually be weak bladder. And when the Qmax is more than 15, only 30% may be obstructed. So the Qmax or the maximum flow rate will actually give us a very good clue on whether this patient is obstructed and how severe the obstruction is. Now there are pitfalls in the interpretation of the uroflowmetry. The unreliable flowmetry may be due to nervous artifact like embarrassment, psychological inhibition, unfamiliar surroundings, suboptimal positionings, and on and so forth. And this can be altered by abdominal straining. Then some people come there to pass urine and they try to push to get a good flow. Now this abdominal straining will give a false impression that the patient actually has good flow. Some people manually compress the urethra, press the urethra and then suddenly leave it out. Then you can get a spike artifact there. So these are things that one needs to know, and one needs to know how to trouble, and one needs to know how to interpret any of these false. Now, what is cystometry? Now, basically, cystometry is filling up the bladder and voiding phase of the bladder. In other words, we put in the catheters in the rectum and the urethra. We fill up the bladder first. It's known as filling cystometry. See how the bladder reacts to the bladder getting full with saline. And then what is known as voiding cystometry, where the patient passes urine and then we check the pressures that are raised in the bladder during the uroflow itself. These are the important pressures that we need to know. The first part is abdominal pre-micturition and abdominal opening pressures are all filling cystometry. And after that is known as voiding cystometry. Okay, where we need to know the abdominal pressure at maximum flow and maximum abdominal pressure after passing urine and so forth. Okay, this is a typical urodynamic test with all the different parameters. We have the EMG, we have the P-ura. I usually do P-ura for all my patients, that's urethral pressures. Then we have intravesical, detrusor and intra-abdominal pressures through the two catheters. And then is the flow rate, assessing both in the storage phase with the filling phase of the cystometry and the voiding phase as well. Okay, these are different pressures that I mentioned earlier. We need to know, very important, we need to know maximum intravesical pressure, abdominal pressure, detrusor pressure, and maximum flow rate, and the pressures, maximum pressures at the maximum flow rate itself. Now, how to set up a urodynamic system is very important, but this one is unable to just give it by a presentation. So it's best for anybody who wants to know about urodynamic need to attend a workshop. Okay, these are the different type of transducers and catheters that we need. Okay. These are various accessories that you need: the pressure transducer, infusion, perfusion sets, catheters, and electrodes for EMG. Okay, how to set up a urodynamic system? Most important, one needs to attend a workshop to know. What we need to know is to set up pressure transducers, balancing and setting of zero, calibrating transducers, calibrating the flow meters, signal testing before the study, and very important, quality control during the urodynamic study itself. So we need to know all the pitfalls, and we need to know exactly how to troubleshoot in case we see an abnormal quality during the study itself. These are the various pitfalls, how you can get false reports, false tracing, and then if you don't determine this false tracing, then it's a bit more difficult for us to make a proper conclusion or urodynamic conclusion. Okay, this is in the filling phase of the urodynamic or the filling cystometry. We can see here there's hardly any rise in the detrusor pressure when the bladder is being filled. Now this is known as a stable bladder, stable compliant bladder. Now this detrusor overactivity, this during the filling phase also, saline is inserted into the bladder, slowly pushed into the bladder by a very specific rate, and you can see there the intrathecal pressure comes up and goes down, due to phasic contractions of the detrusor muscle. In other words, this muscle in the bladder starts contracting even though in the filling phase. Okay, this specific tracing is known as detrusor overactivity. It can be seen in overactive bladder patients, or it can be seen in neurogenic detrusor overactivity. That means all is bladder that is been affected by a spinal cord injury or neurogenic disability. Now this is a neurogenic detrusor overactivity, same like just now, but this is persistent, not phasic contraction, but persistent detrusor contraction. Now this is seen usually in multiple sclerosis. So it is neurogenic detrusor overactivity, specifically seen in multiple sclerosis. Now this is dyssynergic widening. What do you mean by dyssynergic widening? Now synergy is when things have to occur in such a way that the urine flows unimpeded. In other words, synergy widening means when the bladder is contracting, the sphincter must be relaxed. When the bladder is relaxed, the sphincters contract. So in this urodynamic tracing, you see the bladder is contracting, but the sphincter is also contracting because it's very poor flow. We don't have the EMG tracing here, but had we had the EMG tracing, the EMG tracing will show overactivity during the widening phase itself. This is a widening phase. So this is a dyssynergy. When the bladder is trying to push the urine, the sphincter is trying to close also. Okay, low compliance. Compliance we actually calculated or we interpreted during the filling phase of the cystometry itself. Now, low compliance means when somebody pushes in saline or where the bladder fills up, pressure starts mounting very high. Slowly mounts. It's not due to a phasic contraction of the bladder, but it's due to the rigidity, something like a rigidity of bladder where there's a low compliance. So as the bladder starts filling up, actually the bladder pressure should be stable, should be very low, 0 to 5 centimeters water, but here it starts rising up. It's a low compliant bladder. Okay, we can see these low compliant bladders in neurogenic bladders, or we can see it even in contracted bladders like TB bladder, tuberculosis bladders. Okay, now this is voiding phase, voiding cystometry. When the patient is passing urine, like you can see in the lower part is the flow. While the patient is passing urine, the pressures are very, very low. When patient passing urine, this is a low pressure, low flow, unobstructed. Very characteristic of weak bladders. Okay, so this an unobstructed but low pressure, low flow. Okay, this is being put in the ICS nomogram. The tracing. Okay, this is an atonic bladder. That means hardly any pressures come up during the filling phase. This is a filling cystometry. So when they are putting in saline and filling up the bladder, hardly any pressure changes. Strictly speaking, to diagnose, it's a bit more difficult to diagnose hypotonic bladders, but only after a pressure flow study one can diagnose. But if there's completely atonic, they won't be able to pass urine, but the pressure changes are very, very minimal. Okay, this again detrusor overactivity, what I showed earlier, where there's phasic contraction during the filling phase itself. This is how we do a urodynamic report. We putting the tracing, all the pressure measurements are all preset itself during the report itself, and then we have to make a diagnosis ourselves. Okay, this is a pressure flow analysis or PQ plot. here we need to know whether urine flow is obstructed or not, or bladder outflow obstruction. This for males. We have a PQ plot, and we can plot it up there, and we can know whether it's obstructed, equivocal, or unobstructed. This by using what's known as the AG number, or Abrams-Griffith number, or the bladder outlet obstructive index. But this can be traced automatically by the computer in the urodynamic machine itself, and we can see exactly whether it's obstructed or not. This is a female obstructive nomogram. Now in males you can use a ICS nomogram or Schaefer's nomogram, but in females it's very different. So females we have to use this type of nomogram known as a Blavius-Grupp's nomogram. The reason is because unlike males, females actually avoid using some amount of abdominal pressure as well. Some amount of abdominal pressure and passive voiding as compared to males. Okay, this is another concept that you need to know: leak point pressures. What is leak point pressure? Leak point pressures are pressures in the bladder and the abdomen that lead to leaking of the urine. We have two different types of leak point pressure. One's bladder detrusor leak point pressure. The other one is abdominal leak point pressure, which may either be Valsalva leak point pressure or cough leak point pressure. Now, what's the difference between abdominal leak point pressure and detrusor leak point pressure? Now, abdominal leak point pressure we usually use to assess for stress incontinence. Okay, is the intravesical pressure needed to produce stress incontinence during straining or coughing maneuvers. Okay, but detrusor leak point pressure is different. It's a detrusor pressure needed to produce leakage from a distended bladder, especially in a neuropathic bladder. So much of difference. The difference is because abdominal leak point pressure is used during measure of stress incontinence. Abdominal leak point pressure, strictly speaking, is either Valsalva leak point pressure, that means the person exerts the abdomen pressure, or cough leak point pressures. But detrusor leak point pressure is different. That means, let's say for example, neurogenic bladder, which has abnormally high urethral resistance. Now when we fill up, the bladder pressure starts increasing. Now the bladder pressure starts increasing more than 20 centimeters water, and it starts only leaking at 30 centimeters water. That means it's a high pressure bladder, very high pressure bladder, and it can indicate progressive upper tract changes that may result of the pressure bladder, and these are known as dangerous bladders. Okay, so there are two different concepts and indicated for two different uses. This is an example of abdominal leak point pressure using cough leak point pressure and Valsalva leak point pressure. The patient is asked to cough, and one notes when exactly at which pressure the leak occurs. So if the leak occurs in very high pressures, then we know that the sphincters are quite good. If the leak point pressures are very low, let's say less than 60 centimeters water, then we know there's some amount of intrinsic sphincter deficiency. Okay, this is a differentiation between what is known as what is the difference between Valsalva leak point pressure and cough leak point pressure. Many people think it's the same, but actually it's different. Okay, these are video urodynamics showing the leak point pressure. This is actually a detrusor leak point pressures in a neurogenic bladder. As you can see in the image D, that is a very trabeculated thickened bladder seen in neurogenic cases, especially in this case is a myelomeningocele, and this patient exerts very high pressure in the bladder before any leaking occurs. That means this pressure will be transmitted to the kidney. These patients can have hydronephrosis or swelling of the kidney, and which will result with renal insufficiency or kidney problems. Okay, now we come to EMG of the perineal floor or electromyography. Basically, we need to check the contraction of the perineal floor, which represents to some extent the sphincter activity. Okay. So basically, this is an EMG reading. And now when you see here, when a patient actually gets filled up, the EMG activity is very minimal. When slowly the bladder starts getting filled up, the EMG activity increases, which is known as guarding reflex. When the patient starts passing urine or voiding, the EMG activity has to become silent or minimal. And this is what the diagram represents. Now the EMG can be used either using electrodes or by using needles. Surface electrodes are very easy. What we use is skin patch electrodes. There are different types of electrodes available, but practically skin patch is the easiest to do. So what we do is we use two skin patches on either side of the anus, very close to each other, and then we use a ground on the medial side of the thigh, and we ensure that there's no leaking that occurs, urine leaking that occurs near the electrode. If not, it will give artifacts. Now it's very important. One needs to know how to interpret the EMG. Strictly speaking, interpretation, the normal sphincter coordination with retrocontraction is what we see normally. In other words, as the bladder starts filling, the sphincter is silent and starts slowly getting a guarding reflex, then slowly increases. When the patient passes urine, the detrusor contracts, the sphincter must relax, then EMG should be very silent. Okay. Normal perineal EMGs usually demonstrate some activity even at rest, normal biphasic or triphasic type of potentials. With voluntary contraction and reflex activation of bladder filling, EMG activity increases until a full interference pattern is seen. Now, what's the information that we need to know from the surface EMG? Firstly, we need to know whether EMG increases during bladder filling, especially at the end of the filling. This is known as a normal guarding reflex. Does the EMG decrease during voiding? This should decrease. It is known as synergic action of detrusor and urethral sphincter. Now, if there's unexpected detrusor contraction, then sometimes you can unexpectedly during filling phase the detrusor contracts. We need to know whether EMG increases or decreases. This to help to assess whether the patient is trying to suppress an involuntary detrusor contraction or not. Now, this is a urodynamic tracing which shows different case scenarios. You look at A and C. This bladder outlet obstruction, okay, but the sphincter is relaxed. In other words, this is most probably a prostatic obstruction. During voiding, the sphincter is relaxed. Although the pressures are high, the urine flow is poor, this is still is due to a synergic activity between sphincter and bladder. So this is a bladder outlet obstruction due to either a prostate obstruction or any other obstruction where the sphincter is not affected. Whereas B and D shown in broken arrows, it also shows the same type of pressure curves. The pressure curves are almost the same. High pressure bladder with low flow. But here there's dyssynergia of the sphincter. In other words, this B and D is seen in dysfunctional voiding or sphincter overacting during voiding itself. So what is video urodynamic? Basically, it's the same. It's urodynamic, but if you do video imaging of the bladder itself, and assessing how the urine flow comes out using contrast. This is basically a urodynamic tracing, and there you see on the right side is all the video imaging. It's helpful in neurogenic bladder. Here on the left is normal, and on the right an obstructed voiding. You can see the urethra getting very dilated. Same here also. The male normal is on the left side. On the right side is obstructive voiding. The prostatic urethra starts dilating, and while taking this video imaging, we can take it real time. In other words, we can see it getting obstructed and how slow the flow comes out. We can correlate this with all the EMG tracing itself, EMG and urodynamic tracing itself. And we can also use the detrusor leak point pressure to see exactly what's happening to the bladder and whether there's any vesico-urethric. And now what about ambulatory urodynamic? Ambulatory urodynamic is we putting various catheters into the urethra and the rectum, or sometimes some people use certain types of wireless instruments and then put in the bladder. We rarely do this. What are the indications? I think I've explained it before. Patients whom conventional studies demonstrate no abnormalities. It's very difficult to read the tracings, but probably it's indicated when everything else fails, then conventional studies fails, and then you have to do an ambulatory study. In this study, the patient walks around a few hours, the whole day with catheters in place, and the pressures are all recorded on a mobile recorder, something like a Holter's ECG for heart. Same thing, this ambulatory monitoring, ambulatory urodynamic. Okay. I won't go into detail in ambulatory monitoring. Most of the time we don't do it, but these are all different tracings that's seen in ambulatory urodynamics. It comes up to the same thing, but one and troubleshoot all the different false tracing that you can. One needs to know exactly which are the false ones and which are the true. Okay, I think that's about all. Okay, that's about all on the basic overview of urodynamics. This is just an overview. There's a lot of things to know about urodynamics. Probably the best thing is to attend a workshop and then find out exactly what to do with the urodynamics, how to trace it, how to read the tracings. But most important is one need to know many things about urology problems first. Need to know the pathophysiology of micturition, and then need to know the different type of pressures. Need to know how to set up the urodynamic instruments. Need to know how to zero. Need to know how to do quality control, and then finally need to know how to interpret the results. I think that's about all for the presentation. I hope everyone at least have just an overview idea of what urodynamics is all about. I'm Dr. Rajeentheran Suntheralingam. I am a consultant urologist specialized with special interest in the field of urodynamics. Thank you.